السلام عليكم.
عليك.
أشترك.
تمام دكتور نبيل، أنت الآن هوست، كان شير سكرين أو تفتح الفيديو لو أردت يعني.
أوكي تمام. السلام عليكم، بسم الله. أنا اسمي دكتور نبيل الراوي، طبيب متدرب في اختصاص جهاز الهضمي في بريطانيا. I think I'm going to speak English because maybe some people they are not Arabic, so maybe I will mix also the language. So my name is Dr. Nabeel Arawi. I'm one of the training in gastroenterology in the UK.
Yes.
Today we are going to talk about how we can prepare for the interview and how we can score high in the interview and what's the best strategy to have a good succeed and a high score. So high specialty training in the UK, I'm talking about the medicine and the subspecialty of medicine. So as we know, this is included in England, Scotland, Wales, and this started from the range of general medicine, endocrine, gastroenterology, cardiology, all the subspecialty. And I'm going to focus on the group one, which is the specialty where you get the two CCT in the subspecialty and in the general medicine as well. So usually there is two rounds, one in November and one in August. So I think the people who they apply in August now they get the short list or at least or even the score only, and they will get the invitation for booking. The things that I need to mention here that the booking it is first come first served. So I advise if anyone he get invitation for interview, he can open the booking system online and book the slot. It's suitable for him. Usually, for me, I prefer like around 11 or 12 in the midday. So I'm not so tired. It's also not so early, but it's depend on each person preference. But I advise everyone uh, to open and book it very early. And interview preparation should start very early because in this round, round two, August round, usually they send you invitation and they will told you maybe um, the interview it is in a week. In a week. I can't hear you. Is my voice is clear? Hello? Is my voice clear? Oh, okay. Yeah, great. So let's go for uh, the next slide. So how the interview is scoring. So the score usually you will have two consultant or maybe two registrar, let's say two assessor. They have the interview with you online, and each one he will give uh, the mark from 5. So each station is contain 10 point or 10 marks, and each assessor will give you 5 point or 5 marks. So the aim is to get 5 from 5, the full mark. And usually if you get any, and these how they mark you. So if you get excellent, so you have good performance and you show them that you are suitable for the training, suitable for this post, they will give you 5. And if you are not even prepared or you just want to test yourself and knowledge in the interview, you will get 1 or 2, which is it is not satisfaction and it will not help for getting high score. How you will be appointable. So what I mean by appointable, when you enter the interview and your score, it will be like if you are appointable, so you may get an offer and if you are not appointable, you will not get an offer. So to have an offer, you need to be appointable, and that should be in the criteria of you will not get any 1 from 5 in any station, or you will not get more than 2. Assessor give you 2 from 5. And overall, you should have 30 from 50 or at least 60%. And this is different from some specialty, like from cardiology, you need to get 40 from 60 because they have 6 stations. Again, if you get 30 from 50, you are appointable. You may get offer, but that not mandatory you will get an offer, because it is how much your score is high, how much it's easy to get an offer. And also it depends on your preference, and you need to put your preference, and that will be according to your score. So the idea of interview, it is multi-station interview, and all specialty will have an online interview. It is not like before the interview was face-to-face. So now it is online. So you need to familiarize yourself, how you prepare online. Again, many things, many tips, like you need headphone, you need good internet connection. I prefer you can wear a suit and a tie. The environment when you sit in quiet room, because they will ask you to see the room. And all specialty, they have almost the same for station. There are some questions different from one specialty to other. So the station in general, especially for group 1, it is medical registrar suitability and commitment to specialty, and it will contain clinical scenario. Some specialty, they have 1 clinical scenario. Some specialty, they will have 2 clinical scenario. And some certain specialty, they will ask you for presentation, and we will talk about that as well. So regarding medical registrar suitability, here, so the medical registrar suitability, this question, I think everyone in group 1, he will be asked this question: how you are going to manage an acute and selected take. So you need to prepare yourself. You need to put a frame of talk, like in 2 minutes or 1 minute 45 seconds, how you are managing acute and selected take. So for the people who they are overseas or they didn't work in the NHS, usually the emergency department here, they receive the patient, and after they stabilize them, they refer them to the medical team. And usually the registrar from the medical team, he clears this list, or usually they refer them to the medical assessment unit, where the medical registrar, he clear and lead this area. I think the point here, we need to, I will give an example, and each one he can, I prefer each one he can write and practice what they are doing in their trust and how he is managing the acute and selected take. So for an example, I can say usually I attend earlier for my duty, and I check the name in the rota, and I can see who is with me from the doctor, what's their grade, what's their competency. And then I will take the patient list from the nurse in charge or the tracker. And during the handover, I introduce myself, I give my plea to my team, and I delegate the job, and I assign doctors for the resuscitation team or cardiac arrest team according to their capacity, or if they have ALS. Then we will take the handover from the morning from the other team, and I'm sure I need to make sure we're taking the handover in the SPAR method, and this gives us an idea about the patient. And if there are any sick patient, or if there are any patient in the resus, I need to see them by myself. And during we starting the shift, I try to be reachable. I arrange the time management and make sure my team getting their break, and also if there are any opportunity for teaching, or if any of the junior he want to sign jobs, or if there are any help for the team. And also this is during the shift, and before we finish the shift, I have meeting with my team which patient we need to hand over, and during the handover to other team, we hand over clearly all the patients, and if there are any incidents or if there are any area of improvement, I need to discuss that in the handover with the consultant. And sometimes if it is night shift, I need to make sure my team is driving safe. And when I back home, I write a reflection about my shift. So this is the idea. You need to prepare your talk before you go to the interview according how you're doing the acute and selected take in your trust, because it's in some trust, some hospital is different in the way they're doing. Like they're doing the handover on the computer, they're doing the handover in place. Usually it's different from a place to another, but just this is very important because this will give an idea about you in this station. And medical registrar suitability, it is the most common station where all the candidates score low. So, and I think it is easy to master it because you can prepare yourself for it because you are expecting the first question. Tell me how you manage acute and selected take. So you prepare, you know what to do, and that will give good impression about you. Managing multidisciplinary team. So here they are talking about discharge planning. So again, they will ask you, you are medical registrar, how you arrange safe discharge. So again, here you need to say that, again, there is a frame of answer. You need to say this is usually when I work in the ward and the patient is for discharge, I need to make sure that he is safe to discharge medically and he is safe to discharge functionally. Medically, I need to make sure that he has a plan and he has ongoing plan, and this ongoing plan even in the community, and he has the discharge summary or the TTO, and then I need to make sure the medication was prescribed, and I need to make sure the letter was written to his GB, and if there are any safety netting for the patient, and I need to document that. Functionally, so I need to make sure if there are any involvement of the SALT, social, physiotherapy, and if this patient, he will go home. If this patient, he's going to home care, nursing care, the communication with the family, and if the patient need any special need, if he need any carer at home who is going to give him medication. So this is like you are working with a multidisciplinary team from the pharmacist, physiotherapy, and all part of the team. I think this question, it is mandatory. You need to master it, and how you do it in your hospital, just write it. You should answer this in maximum 2 minutes. I prefer is 1 minute and 45 seconds, and just repeat and practice it. So the next question, which is also common, and it will be shared for all specialty, the suitability and commitment. And here they will ask you why you choose this specialty. And some people, they said, oh, I like it. I like endocrine. I like gastroenterology. And I think this is not the perfect answer, and they are not looking for this answer. So they want to see you really like this specialty. So if you like something, you need to work on it. So in this station, they will give you opportunity to expand the information you put in the application form, and you need to provide information in a matter they understand it. So there's something is called CAMP, which is Clinical, Academic, Management, and Personal. So usually if they ask you, what's your commitment to this specialty? Or they will tell you why we will choose you. Again, so you will answer your clinical experience, like as a part of my commitment to specialty, I work in the gastroenterology for 1 year, and I attend outpatient clinic. I have my own clinic. I attend endoscopy unit. I did some like procedures, and all these clinical experience, it should be also prepared according to your specialty and according to your what you did and what you put in your application. And this experience, you don't need to tell everything, but you need to tell the focal point, which is the outpatient clinic, the ward, if you did any weak tester, all these important. Then academic, what I mean by academic, you can start that I am member in the like gastroenterology society, I am member in the endocrine society, I read their guideline, and I keep myself up to date. Again, academic, you need to say that I attend a conference of this specialty and I learn 1, 2, 3. Like I attend basic upper endoscopy skills, and I learn how to handle the scope. In academic also include I lead an audit or QIB. In this, I lead audit or QIB in this specialty because I improve my understanding to data collection and clinical governance for this specialty. Again, in the academic, if you did any diploma, if you did any master or PhD, you can mention that as well. And also in academic work, if you deliver any organized teaching, like I delivered 6 months organized teaching in acute gastroenterology emergency cases once every 2 weeks, and I get formal feedback for that. So clinical and academic work combination, it will give you the commitment and specialty, a commitment to specialty. And why did you choose this specialty? Because it is important to show them I choose it because I like it, but you need to prove that by your clinical experience and by academic and work. And again, sometimes why you are good candidate. So you can link that I'm good candidate because I attend the clinic for this specialty. I did 1, 2, or 3. So these 2 questions is universal in group 1. In group 2, there is no medical registrar suitability, and it is more like scenario. So they have 2 stations of scenario like hematology. However, so in clinical scenario, also in all specialty, unless you will get 1 or 2 clinical scenario, and this clinical scenario, it is like 2, 3 sentence. They will give it to you before the interview. So it will appear on your screen, and you can use paper and pen, and you can write a note. So in this 2, 3 minutes, it is very important to structure what you are going to do. So a clinical scenario is not difficult. They will not bring something is like rare. No, they will bring something is very obvious, but they want to test you how you are going to approach. So for example, they will give you this patient come with jaundice for 3 weeks, how you are going to approach. So again, here, they will test you, but the main issue, it is the time, because you have only 6 or 7 minutes. So in 6 or 7 minutes, you need to cover all the area for this scenario. So what I recommend, the approach. So the approach should be focus history. So it's not like I'm going to ask very long history. No, I will ask 4 or 5 questions in each presentation. And that was very important for me to get the diagnosis. Like for this jaundice, is this first time? Is it painful or painless? Is there any vomiting? Is there any diarrhea? So this, and is it continuous or intermittent? So again, it is very focused. And when you get this information, usually they told you very easy, this is like painful associated with abdominal pain and sometimes nausea, and it is after food. So here you can go for the other part of history. If there are any relevant systematic review question, and also you need to ask about the drug history, medication. Is this patient taking any medication? They will tell you yes, he was started on fluoxetine for cellulitis 10 days ago. So that's give you the clue. But again, you didn't reach full diagnosis. You need to do the full workup for this patient. And when you finish your like drug history, social history, family history, and if there are any past surgical history, when you do the focal history, and you don't jump just I will send this patient for investigation. No, you need to examine this patient. And again, just form in your mind that I'm going to do a general examination for this patient. I will look to his vitals, and then I will do local abdominal examination, looking if there are any abdominal tenderness or if there like ascites. And I just, in general examination, looking for to confirm the jaundice, and local examination to see if there are any abdominal tenderness. So when you start with history and you follow that by examination, and after that you need to do the proper investigation. So you said, I'm going to send this patient for investigation 1, 2, 3, 4, like ultrasound, like blood test, to see how is the trend of liver function test deranged, and maybe I will send some image like ultrasound, more specific test like viral screen, or maybe more specific image like a CT scan. So all these, it should be in frame in your mind. So again, you are not testing yourself in the exam or in the interview, because everything should be prepared. The time is very narrow. And when you reach to the management plan, you don't need to mention those, or just you need to be safe, whether this patient need to be admitted or be discharged, whether this patient, I will give him some IV fluid, I will stop the medication, I will reassure him, all these. And the management is not stopped here. So, and you need to provide the continuity of care. So what happened if this patient admission? What happened if this patient discharged to community? And what will be the follow-up? Like in case of DKA, new presentation of DKA endocrine. So this patient should be admitted, and the continuity of care, it will be continue in hospital. And when they discharge him to community, also he will need continuity of care in the community. And this is also the follow-up. And the follow-up is important, because how we are going to follow this patient, whether he will come to the outpatient clinic in 2 weeks or 3 months, or he just will follow up with his GP, and also the referral and special advice. Did this patient need to refer to other specialty? Like the patient with new diagnosis of diabetes, you should refer to the ophthalmology for first eye check. So all this is different from one specialty to other, but again, you need to frame that in your mind, and they will not bring very like strange or very difficult scenario. They bring something obvious, and I think you should just for each specialty just familiarize yourself for each presentation. And I will back to this, and during the clinical scenario, they are going to assess your communication skill. So the communication skill is important. So when you said, I'm going to manage this patient, I will admit this patient to the hospital. So again, if you are admit this patient to hospital, you need to communicate with diabetic nurse, let's say the DKA case, or you need to communicate with the dietitian, or you need to communicate with the diabetic food, or any other specialty, or with the physiotherapy, or if this patient need any other specialty to involve. So they will test your communication with other specialty, and also they will test your communication with the family, or your communication with the patient. So you need also to say, I need to explain to, we need to find an opportunity to explain the diagnosis for the patient, and make sure he's understanding all aspects of the disease before discharge. So usually when you have 4 stations, but the 5th 10 mark, it's come from communication skill, and this mark is coming from the clinical scenario. So this is communication with any people, like patient, family member, colleague. It will involve in each scenario. So usually they told you, okay, this patient was on this medication, so you need to contact the GP. Please, the patient get jaundice because of this medication. I'm going to stop it, and if you could just follow up in like a week. Good. Presentation. So in some specialty, like in urology, gastroenterology, I think hematology as well, they ask you to present. It is 1 station of presentation. So in neurology, it's 3 minutes, and in gastroenterology, it's 4 minutes. And what you need to present usually it is a case report that you involve in the management of this patient, but this presentation should has a clarity and important point. And also the learning point, it is included in the 4 minutes. So what you need to do for this, the people who apply for like neurology or gastro or any specialty with the presentation, you need to write it, ask your colleague to review it, or ask your consultant to review it. And all these can help you to become optimized to 4 minutes or 3 minutes. And really it is important, because if you finish three minutes, it will be, you will get half full mark. But if you finish like in let's say in gastroenterology, if you finish in 4 minutes, you will get the optimized time. But if you finish in 3 minutes, they will say he finished early, he didn't prepare the case according to time. And if you finish in 5 minutes, they said they will stop you. And in that case, usually they will minus you 1 or 2 mark. So practice on it, try to say it in front of the mirror, record it, send it to your colleague, send it to your consultant, ask them to see what's the learning point, is it good or not, how is the clarity, how is the important point. And the presentation, you need just to say one line of presentation, one line in why the patient presented, what's the investigation, what's the examination, and why this important to you, and what was the plan, and what's the learning point. So again, learning point, it is very important because they will ask you about that. In gastroenterology, you can review a paper and see how this changed your practice. Again, it is also a challenge which paper you need to choose and how that can affect. So when you finish your presentation, it will be a discussion after that. So the two examiner, they are going to ask you everything about your presentation. So if you present, let's say, drug-induced liver injury, they will ask you everything about drug-induced liver injury, because you present this case, so you should know everything about this presentation and this case. Okay, so in most of scenarios, usually there is an ethical scenario. And I think the people who they didn't work in the UK or in the NHS, they find it is challengeable, because the ethical scenario, it is very, let's say, it's very difficult for the people who they are not involved in it or they didn't work in the NHS. So usually they ask you what's the ethical in this scenario. Let's go back to the DKA patient. You should ask about driving, because this patient, if he's drive, and we start him on insulin, there is a special criteria how long he should not drive. Again, if this patient is coming with palpitation and syncope, he should not drive for 4 weeks. Or if this patient had an OGD, you should mention that, okay, this patient, he will need a gastroscopy, but I need to mention for him, if he gets sedation, he should not drive for 1 day, 24 hours. So ethical scenario, it is include inside the scenario. And the people who they get geriatric medicine and general medicine, there are a lot of complicated interfering ethical scenario. Especially in geriatric, there are a lot of ethical scenario, like if this patient refuses the treatment, if this patient family, they want him for DN CPR, but he wants DN CPR, how is the discussion happen? So usually any case or any scenario, you will get a question. Like some people in respiratory, they present for them a case who had fatigue, and in the end it is sleep obstructive apnea. So they should ask about the driving, which type of driving, and they need to advise the patient not to drive until full assessment is happened. And if it is driving license 2, he should not drive. So this is the hidden clinical scenario in each scenario. So it's a good idea if you read the GMC domain of good practice, which is the 4 domain, clinical, keep my knowledge up to date, good relationship with the patient, good relationship with the colleagues, and I need to be honest and work according to law. Mental capacity, so assessment of capacity also sometimes it's important. So they will told you there's a patient, he come with upper GI bleeding, but he was not able to consent. So during this, they said this patient come with upper GI bleeding. So you need to make the workup whether this is varicose bleeding, non-varicose bleeding, resuscitation, examination, and he will need endoscopy. So when you said he need endoscopy, they will told you, okay, this patient, he doesn't have capacity. What you will do? So here you need, the first thing you need to say, I need to make sure and I need to assess his capacity and make sure it is documented according to the time and date, because capacities can be different according to time and date. Again, the consent, refusal of treatment, and duty of candor. I think the duty of candor, it is mean that we need to be honest with the patient if we make any mistake in the treatment, and we need to be open to learn from this mistake and make sure this will not happen again. As I said, the people who they didn't work in the UK, they find this is a bit difficult, but this is the practice here. So another question, usually they ask you, and what do you know about portfolio? Because this is things is linked to the training. So the portfolio, it is the platform where you apply and upload all your evidence of that training. So anything they ask you about portfolio, professionalism, clinical governance, you need to define it. So it is useful curriculum used to ensure training develops on the track. And this platform is used to collect the data for requirements for each year. And it can be, and it is we can send a ticket, so we can create a ticket and send it like CBDs, ICAT, and DOPS, and these all, it is a requirement for each year in the training. And also from the e-portfolio, we can send the formal feedback by multi-source feedback or multi-consultant feedback, MCR, the other one, multi-consultant feedback. And also there is a library and where we can upload our certificate. And all these, it is needed for something is called IRCP, which is appraisal, and it is every 1 year in your training. You will sit with your education supervisor, and I don't want to go and revalidation in 5 years. So the portfolio, it is the platform where we can prove that we are on training, on the track, collecting the data for the end of year appraisal. Another important question about clinical governance, which is something unique for the NHS. So the clinical governance, it is a systematic or it's a framework for improving and maintaining the quality and safety of healthcare service. So usually they ask you one of these questions, whether it is about portfolio or clinical governance, and that come after the question of, it will come in 2 places, unless after the question of commitment or after the question of commitment to specialty or in the medical research suitability. So clinical governance is a framework to improving and maintaining the quality and safety for healthcare service for both patient and also for the staff as well. So in other meaning, it's doing right thing at the right time by right person. But here, when they ask you about clinical governance, there are 7 elements. And for each element, you need, so the next question they will ask you, what do you know about clinical effectiveness? Or what do you know about clinical audit or risk management? So here you need to, again, to say and give an example if you involve in that. Let's go for risk management. So the risk management is the process where we can make sure the patient and the staff are safe and trying to prevent any harm for both of them. And an example of that, cross-infection in the hospital, and hygiene. And you can say that I was involved in an audit regarding hand hygiene and how the staff compliance to hand hygiene protocol. And we find that not all the like 85 or 80% of staff, they are cleaning their hand before touching the patient, but the other 20 not. So this is like a part of risk management. Or you can say that we have an audit regarding the people who they coming. We have an assessment for people who coming with fever and the travel history. So we need to isolate them, not mix them with the other patient. So again, you need to make sure for everything is quality and safety. And also you need to give an example. A clinical audit is the same. What's the clinical audit? It is the tasting clinical practice against the guideline and how we are sticking to the guideline. And you need to give your experience that I lead an audit about upper GI bleeding and how they are sticking to upper GI bleeding bundle published by BSJ. And I found that some junior doctor, they are not aware about it. I did presentation and extra. So e-portfolio and clinical governance, again, you need to prepare the definition and you need to read about it because you will get a question about it. Another question about professionalism. So again, this is part of GMC good practice, and it is the framework setting to make sure that we are a good doctor to provide the care for the patient. And these are the 4 elements for GMC good practice. I recommend everyone he can read it and just Google it, GMC good practice. You can read it. It will take maybe 10-15 minutes from you. It is important because sometimes they told you, what do you know about professionalism? And just you need to have the definition. So the 4 elements, it is keep your clinical skills and knowledge up to date. And second one is to work well and keep good relationship with both colleague and patient. And third one is work with honesty. And fourth one, it's work with integrity and with law. I think it's very important because if you didn't read it and interview that ask you about it, they will give you 1 from 5. It is very important. Okay, so in the end, you need to prepare yourself. So it's not the day of interview. You are going to say, okay, my name is Nabeel. I work as like that. No, you should prepare yourself. You should prepare every question and go for your application, read it, master it, and see what did you write, see what's the important point you put in it, because when they interview you, the application in front of them, and they are going sometime to ask you, you wrote that you attend this conference, what did you learn from it? So everything should be prepared in your mind. So prepare your CV, like they ask you, could you take us through your CV? Or they will ask you, tell us about yourself. So you just need to say, my name is Nabeel and I work. You need to mention not all the work history because they don't like to hear, and the time is not appropriate because you will have only 1 minute to answer this question. So you will not say, I finish F1 in this hospital, F2, no. The most recent work that you did, and just start from there. And also prepare yourself about the audit and the QIP. And if you put you lead or you involve in audit or QIP, they will ask you about it. So again here, they will tell us about your audit. So you will not say, okay, I have an audit regarding upper GI bleeding, which helped me to understand data collection. No, the frame of this answer, you said, I noticed there is an area or there was an incidence regarding a patient who come with GI bleeding. They didn't stop his blood thinner. So I suggest to my consultant that I need to run an audit about the upper GI bleeding bundle which is one of the elements of tick box. It is to stop blood thinner. So I make a data collection, and I found there is non-compliance to this bundle, which is national guideline. And after that, I deliver a teaching. I deliver teaching for the nurses, for the juniors in the MAU and in the emergency department. Then I re-audit this, and I can see the improvement in the data collection and documentation, and even in the patient care. So it is like 1 minute or 2 minutes, but it's very focused, and it shows that I suggest the audit, I lead it, and it makes change in the practice to good way. Teaching experience. So they will ask you, tell us about your teaching experience. So you need to say that I organize regular teaching for emergency cases coming for in the endocrinology. It was one session every 2 weeks for 6 months, and I have a formal feedback for that. And each session was better than before because the feedback, it was informative and give me good suggestion. Yeah, so always answering this question according to what's your experience or what did you put in inside. Usually they ask you outside medicine, how do you de-stress yourself? I have this question actually for me. So again, the interviewer, they want you, it's not only about knowledge, they want to know that everyone, it is understanding the medicine and outside the medicine, understanding the life, and the life, the work, lifestyle balance, it's important as well. So you need to answer that, how you are distress yourself. So some people going for hiking, playing football, playing music, each one with his lifestyle distress. There is some question maybe you will get asked or not. So they will ask, where did you see your specialty in 5 years? Like, let's go for sorry, let's go for gastroenterology. Where did you see your specialty in 5 years? So I can answer that in the development of artificial intelligence and how that help us in interfering the colonoscopy image. So it can help us to improve the polyp detection, and that will improve each year after year. Or even you can say, I can see the gastroenterology after 5 years, like the new medication for IBD. It is a new generation of JAK inhibitor medication, which I think it will make different in the practice. Or maybe you can say, according to the medication of treatment hepatitis C virus, I hope in 2030, the hepatitis C will be eradicated from the UK. So the hepatologists will focus more on other disease. Usually they will ask you sometime in the commitment, what's the new development in your specialty? So they will ask you, what do you know, any like new development? Let's say for endocrine, if there are any new medicine like GLP-2, for gastroenterology, using of the green endoscopy. I'm sure in each specialty there is a new, like for respiratory, there is a new guideline for the pleural pneumothorax and the pleural paracentesis, how they are doing the pathway. So in each specialty, there is something is new, there's something is going on in the development. You just can also Google it or go to the specialty association and see what's the new research about it. Important thing that when you say that I attend conference, and you will not say this conference was talking about endoscopy. No, you need to say that I attend a conference and I learned from this 1, 2, 3, 4. So usually they will ask you this question. If you said I had an audit, if you didn't mention that I learned from this audit how to make an idea to how to make the idea to a project, and I can see it how it is affect the patient safety, they will tell you, what did you learn from the audit that you did? Usually you need to frame your answer. So each person he learn a specific point. Some people they learn how the data collection. Some people they learn how they analyze the data. And also for me, I prefer to say I learn from that an idea, how I make the idea to a project and share with the team. I work with the team and make this idea to affect the patient safety and improve the quality of care. Cool. So prepare early, succeed to secure the seat early. So if you prepare for interview very early, we can guarantee that you will get the seat early. And again, it's not framework for each. It's one framework for all. Each person he should have his framework according to the work he did, according to his application, according to his score and the specialty. Because there is difference between one specialty to other, there is difference between one application to other. Some people they have publication and research, so they need to talk about the research, how they involve, what's the value, is there any change in the clinical practice. So this is the end of the presentation, and I'm going to have the some question. Okay, just let me. Okay, so is there any question? You can raise your hand, so I will ask you to unmute yourself. Let's go for the chat. Sahran. So Zahran, if you have a question, just raise your hand so I can easily unmute you. I ask you to unmute.
Thank you, Nabeel. Thank you so much. Can I just ask you a question about the camp, like let's say pathway? You said you would mention about your clinical work and then academic work, but then what is the M&MP stands for?
Yeah, because usually in this interview they will not allow you to complete everything. So the camp, it is a clinical, academic, management, and personnel. So if you're going to talk about your management, it's the same thing. What did you put in leadership or management? So you can say that usually I arranged the rota for the juniors. I had lead of this area, or any particular management or leadership. You need to mention it. Even if you attend any leadership course, it's a good idea to mention it in the management. And for the P, it is personal. So you need to say that the personal issue, the personal things that I am the people who they like the balance between life and work, and I like to work to live like the people who live in area which is like sunny south of England. And I hope my hobby is 1, 2, 3, like playing football, hiking, and I usually use this for de-stress myself.
Okay, that's clear now. Thank you so much.
Good. So there's a question: what is the needed time for good preparation? So good preparation I think is 2 or 3 weeks is good, but you need a partner for preparation. So if you are doing that alone, it's be a bit difficult, but just find one partner and just any person with you, so they can they can assess how you are talking. I think the main issue is we are not native English speakers, so when sometime we are finding difficulty to say the word or say what we want to do, it is in our mind, but we don't know how to say it, how we express it. Okay, so I think 3 or 4 weeks is good, but you need to find someone with you. If you don't have anyone, just say that with your children. Tell them, see, I'm going to tell you something, you will not understand it, but just listen to me. 1, 2, 3, 4, and just prepare yourself how to say that. Ahmed Khafaji, the alternative pathway certificate could be signed. Do you or ITU experience? So the alternative certificate, there is instruction in the first and second page who should sign it. Usually it should be from the medicine, or if emergency, acute medicine or ITU, but he should have full MRCP. So the person, the consultant who should sign it, he should, unless it's from consultant in medicine or medicine specialty, and after that he will, if it is ITU or emergency, he needs to have MRCP. Yeah, Abdullah, I ask you to unmute.
Hello, good evening. Nice talk. My voice is clear?
Yes.
Yes, I'm now in the process of GMC registration, planning to for gastroenterology training in UK.
Okay.
Maybe for next year. So you
Good.
can give us general advice in the preparation for this 1 year
Yeah.
to get training boost.
Yeah, so the gastroenterology and cardiology is very competitive specialty in the UK. So you need to score high in the application, and you need to score high in the interview as well. So what you can do, you need a gastroenterology experience by attending clinic, endoscopy unit, and some courses and conference. And that will give you some commitment. And you need also to do like basic upper endoscopy skills or colonoscopy skills score course. And these are important because that will show that your commitment to specialty. What I advise also, you can also do a regular teaching, like for 3 or 6 months, once every 2 weeks or 3 weeks, for a topic you find it interest. So with the junior, and you need the formal feedback, and just organize this teaching for 30 minutes or 45 minutes. And that also show that you are interested in this field and you start to teach people about it. I also recommend, if you want to do online diploma or master, because that will give you one on application, and that will give you a score, good commitment, showing good commitment. And you need to prepare for the gastroenterology cases. Like usually they ask about upper GI bleeding, jaundice, acute colitis. You need good knowledge in the interview. But what you can do in this year, teaching, clinical experience, some academic, as I said.
Okay, thank you. What about example for the online diploma you mentioned?
Yes. So there are few diploma running from some university. South Wales, I think Queen Elizabeth from London. So there are a few university they can give online diploma, 1 year study or 2 year of master.
Okay, thank you.
Welcome. So here, another question. How can you maintain your well-being during shift? So this is also sometimes they ask you in the medical registrar suitability. So the answer of it is according, again, to what you do. But if this question for me, I will say, usually when I'm doing my shift, I start to delegate the job, and I will put a plan, and I put timeline for, and I will dividing the cases for all the doctors. So in this case, each doctor, he will have the job to do. And during the shift, I need to make sure that I am well hydrated, and I take my regular break. And also I need to have good communication with my team. And if I find myself struggling, always I remember there is a consultant, he can help me whether I need to call him or not. If I struggle with cases, I remember also to work that I am in a team. So if I need any specialty, I can call them and I can discuss with them the case and ask for advice. So the important thing, so it is about planning, time management, about taking regular break, good hydration. If you struggle, you need to know that you have a consultant, and if anything, you can escalate to him. And you can say also, when I back home, I try to make sure that I have good sleep, good rest, and all this. It is important for well-being during the take shift. Is 3-week preparation is enough for interview? Yeah, I said I think 3 weeks is good if you start from now, because usually in round 2 they will ask you just book after 1 week or 10 days, because the time frame is very short. 3 weeks is good, but you need to have a practice, read and prepare for your specialty. I hope I didn't miss any question. Is there any other question? Is everything is clear? So one thing I want, if possible, I just make this feedback form. So if anyone can fill it. Oh, okay. I think it seems there is 2 questions. Let's go for Hatem. I am asking you to unmute.
Hello. Thank you for your interesting topic. I have a question regarding. Can you hear me?
Yeah, I can hear you.
Yeah, I have a question regarding registrar suitability. How to avoid admitting multi-complex patient if you are a registrar on call to the hospital. I have received a question like that before. I didn't prepare well to get a full answer. I mentioned the STEC, but I couldn't understand the full community services that can help.
Yeah. So did you prepare for it?
This time, no, it's not yet.
Give me a minute. So usually how to avoid an admission, all the hospitals, they don't like admission. So you can say that if I am on acute take and if I need to avoid admission, the first things I need to make sure the patient safety. Is this patient is safe to go home and follow up by any other hospital pathway, like hospital at home, as you said, ASDEC, or bring him back to the clinic, or HOTI clinic, or follow up in community by the nurse, community nurse, or by the GP. Again, you need to mention that I need to make sure this patient is safe to go home, and what's the ongoing care plan, whether I'm going to bring him back or not. And you need to give an example. Let's say for the gastroenterology, like a patient is coming with a jaundice for 5 days and his vital is stable, and his pH is stable, his lactate is stable. So I suspect maybe he get drug-induced liver injury. I stopped the medication. I referred him to the jaundice hot clinic to be reviewed within a week, and I arranged for him to repeat a blood. I safety net him, and I told him when he need to come back if any of these symptoms develop. And for like TIA, stroke, because always there is like chest pain clinic. So we receive this patient, it look like stable angina. You need to say the things, and you need to give an example. So always there is an example. As I told you, the patient has come with chest pain, his ECG is fine, serial troponin is normal, he's not expressing any pain now. I have discussion with the cardiology reg, and he advised me to refer him to the chest pain clinic. I give him GTN spray, and I safety net him when he needs to seek medical advice. I make sure that he is safe, and I send him for referral to the chest pain clinic to be reviewed within a week. So this is the an example for that. I hope it's
yeah, it is clear, and I think I have done it many times, but I need to think about it when they have asked this question, because sometimes when you have just ask you the question of how to avoid, you forget all these examples. But yeah, I think you need to prepare yourself. It's very clear. Thank you.
Yeah, again, it's not the time to test yourself in the interview. So try to collect as much as a question that you heard about it, put an answer for it. And when they ask you again, because most of the question, it will be repeated.
Yeah, definitely. Yeah. Thank you.
Thank you. And I think we get Muna. So Muna, you can unmute yourself.
Yes, thank you, Dr. Nabeel, for your time in presenting this nice topic. I just want to ask if I have some of the like requirements for the training from the overseas, and still it will be like accepted when I go there. I mean, and apply for training to get overseas requirement. I can apply using it. Like I'm doing auditing now for example, VTE prophylaxis in admitted patient. Then can I take that one and give it like a requirement? And then which document should I bring to them? Yani, from the hospital, it should be like some certificate that I'm part of the auditing team and I did this and this, or which document?
So for audit, you just need a certificate that you involve in 1 cycle or 2 cycle or QIB project. So it's from your education or quality department that you involve in this QIP. For teaching, you need to provide the formal feedback. So if you deliver any teaching, they will not accept only the certificate. They are insisting to have the feedback. And for any other evidence, it's just certificate, but only for teaching, they want you to provide feedback. I hope this is clear. Okay. So is there a save score for interview invitation? Is there a safe score for interview invitation from the application score? So the way they are calculating the score, they explain that in the website. So your application score will be multiplied by 0.4, and your interview score, it will have the heavy on your total score. I believe you should score at least 40 from 50, let's say 80 from 100 to secure a seat and to get an offer. For that reason, I mentioned that you need to work for 5 from 5 because if you miss 1 or 2 points, maybe you will get 4. But in the end, the minimum it should be 40 from 50, or like in cardiology, it should be 50 from 60 to get an offer, because usually you are competitive with people who they prepare for months. Maybe most of them, they are first or second trial for this application. The record, I think the record, it will be uploaded on YouTube with Dr. Muhammad on, but I will try to, when it's ready, we will make that in the YouTube, so you can see the record. I'm not sure about the discussion, because I think the discussion will not include in the record. Is there anyone who want to do interview mock? Anyone interesting before we go? Jude? Okay. I will ask you to unmute.
Yes, hello, can you hear me?
Yes, I can hear you.
Okay.
Which specialty you apply?
Gastro.
Okay, good. Did you have interview before?
No.
Okay, this is first time.
Yes.
And did you work in gastro before?
Yes.
Oh, great. In the UK?
Yeah.
Great. So let me open the timer. Are you ready?
Yeah, I should be.
Okay.
I think so.
So in the gastroenterology, we have 4 stations. Usually, it's roughly you start with unless registrar suitability and commitment, or you start with a clinical scenario. I will start with registrar and suitability. And your name is Jude, right?
Yeah.
Yeah. Okay. So Jude, could you tell me how you are managing the acute and selecting take in your work?
So I would first of all start with checking which team I'm going to be with, working with in my shift. So who's the F1s, who's the SHOs? Are they going to be in, or is there any sickness? Because otherwise I will manage with the rota coordinators or the site team if we are working out of hours to provide enough staffing. And then when I walk in, I would start the handover with taking the handover from the other team. So I would point out who are the sickest ones. And then once we get the handover, I would delegate the simplest task to the F1s and then the SHOs according to their grade, experience, and where they normally are based, which wards they are normally working at, to make everyone more familiar with the cases they're dealing with. I will go off and review the sickest patients, make sure that they have plans in place.
Yes, carry on.
They are clerked, they have plans, they are clerked. Everyone who needs to be referred to I2 has been there, or any referral, like everyone is safe to make sure that safety is in place. After that, I would ask all my junior team if they are happy with the clerking, if they have any questions. The ones who don't have much experience, I would go personally review the patient, make sure that the plans are in place and they have started receiving their treatment.
So what do you mean? Thank you for that. What do you mean by the handovers? What do you understand by the safe handover?
So the safe handover is that like when I take a handover from the previous team, I want to make sure what have been done for the patients, who are the patients waiting, what they are waiting for, have they been post-taked or they haven't been post-taked, what are the plans in place that need to be done, if there is any continuity of management after they have been seen and clogged that need to be done. We're going to do that, like review blood gas, like review repeat bloods, check oxygen settings of a BiPAP or an NIV, etc.
And if you come and you find that one of your colleague is sick, one of your SHO is sick, and there is 25 of patients waiting, how you are going to manage that?
So I would seek my resources, first of all, try to see which team is in. Normally we have a team covering the wards and a team covering the take. So if there is enough staffing on the wards, I would just call my colleague registrar who is covering the wards if he's happy to send one of the juniors to help with the clerking on the take, if that's the case. Otherwise, I would escalate to the site managers or my consultant if it's too busy, because I've been through a similar situation and I was lucky that they managed to send in a clerking doctor from another site. Otherwise, it's just about prioritizing the sickest patients and then go through the ones that are more stable in terms of safety. Safety is the priority.
Okay.
Patient safety.
Great. And could you tell me about your leadership experience?
So my leadership experience, I have been the clinical lead for a year and a half. I was leading the rare metabolic disease clinic, mainly screening patients for Gaucher disease, Gaucher type 1, and referring them for treatment. That changed their lives because Gaucher disease is a metabolic chronic disease. If it's undiagnosed, it will affect the quality of care for those patients, and it's a treatable disease.
And could you tell me how you support your junior?
So I support my juniors by being very approachable. I ensure to them that they are welcome to ask even the silliest questions. I'm always available. We create a WhatsApp group besides the bleep numbers so that we have a faster and quicker access. Ask them to share everything in that group they are not sure about. I make sure that everyone is happy and comfortable with their clerkings and the patients, and make sure that they take their breaks. If anyone is feeling unwell, I just ask them to hand over, and I've sent people, I've sent doctors who are unwell home because they are sick, and maintain that there is someone replacing them.
And when you send them home, you need to make sure they are safe to drive home.
Exactly, yeah.
So I just will make it 5 minutes because it's good answer. I will give you the feedback for handover is good. Acute unselected take is good. The handover, so usually what you need to add, that when I have a handover, I need to make sure there is a safe and quiet place, there is a confidential place, there is a good place we can sit together and we can have the information. I need to make sure the quiet place, confidential, and taking the handover by SPAR method. Just mention that, like this, okay? But overall is good. And regarding if someone is sick, so what you said is good, but if there's no one to help, you need to escalate that to your consultant, you need to escalate that to the site, and I need to discuss with the ED consultant, and I will told him that we have a shortage, and to let him know if any patient referral there, at least they can help to write his medication, and if there are any sick patient, they can stabilize him before they refer them. Leadership experience is completely wrong. Sorry. And this is one of the questions all people, I think they have the pitfall in it. So when they ask you in the medical registrar suitability about leadership experience, so they will not ask you that you were a clinical lead or you was doing the rota. No, here they want to see, and you need to show that you was the only person in that day and you lead the team regardless what's happening, and you was safe with the patient, your team was happy, and you complete the list. Like I came in the weekend and the consultant was sick, so I lead the team, and because I'm the senior person there, and I contacted the ED consultant, I told him that I'm going to lead the team, I delegate the job, and I do the post-take with the team. There was a resuscitation and we need to call the ITU. I discussed with the ITU. Then I manage all the shift. By ending of the shift, I give the handover, and the consultant from the handover, he give me the good feedback that all the team was happy, the nurse in charge was happy, and my junior was happy. So you need to show, I think everyone he had a bad night, whereas everything is gone bad, and just put it in your mind and say it in 2 minutes or 1/2 minute. So this is the leadership experience when they ask about it.
So it's basically being the med-reg overnight, similar to that.
Med-reg or hospital call you overnight. Okay. And what you say about supporting junior is good, but I just will add 2 points. 1 point, I need to support them clinically if they want to sign any DOBs or anything. It's good. I need to support them sometimes personally, like if they are new to the trust or if they are struggling or if anything, I can help them. Okay, let's go for commitment and specialty. So could you tell me what's your commitment to gastroenterology?
So I've been working as a gastro registrar since April 2022 as a trust registrar. I have been running ward rounds on the gastro ward, also been doing clinics once or twice weekly clinics, gastroenterology clinics. I have a dedicated endoscopy training list once weekly, and I have evidence on JAG. I've also attended multiple courses. I'm a BSG member, and I have provided teaching, regular teaching. I am an Imperial College associate clinical teacher for the gastro 6th year medical students. Yeah, so this is my daily work in a gastro environment, which is I'm interested in. I have one audit and one quality improvement project that I completed during my gastro work. I've also published two published case reports in gastro, one in luminal gastroenterology and one in hepatology, metabolic diseases.
Good. So what you said is good, but I think you need to say it more and more structure. Like you said, I published 1 or 2 cases. I'm not sure whether it is 1 or 2. No. You should like be frank. And you should say that in more confidence. I think you just need to work on the structure. What I advise you just can write it and just say it again. I work in gastroenterology department. I run a clinic. I have my own patient. I work in the gastroenterology ward. I do the post-take, and I have a good discussion with for the complex cases with the consultants. And I have my logbook for the procedure that I did. And I am a BSJ member. I read their guideline. I attend a conference for them, which I learned from them how to do the basal or cirrhosis bundle. And what you mentioned about I am one of the tutor of gastroenterology for Imperial College. I published 2 research. From that I learned how the research is important in gastroenterology because it's very rapid expanding. And also you can just mention that the gastroenterology, it is one of my favorite because it's need like good communication, good interaction between the clinical skills and knowledge, which I have. It is good, but I think we just need to restructure it and form it again.
Yeah.
So what did you learn from your audit?
So so the audit, I haven't re-audited, like it's just 1 cycle, but I have done another quick of a whole 2 cycles. So my audit was about screening which patients have been referred with patients with like liver cirrhosis have been referred for esophageal varices screening, and how much they were adhere to the Baveno 6 criteria.
What did you learn?
So I learned that from the results that I got was that there was a significant number of patients who had unnecessary OGDs to screen for the varices. So they were exposed to an invasive test unnecessarily, and that also costed the trust extra money, which they could have saved on other patients and other procedures. So there was plenty of room for experience to change that.
Good. So again, when they told you what did you learn from your audit, it's different from tell me about your audit. If I ask you, tell me about your audit, you need to say that I noticed, I great idea, and I go through. But what did you learn? So I think it's a good idea if you say the first things I learned, it is how to work with the team and how I can collect the data from different system and from different team, like from the GB, from the cirrhosis nurse, and from the endoscopy, and how I can analyze all these data. And also I learned that the result of audit can improve the patient care, and it can make or avoid the patient to have an necessary invasive procedure. So this is the thing. So just start with that. I learned how to work with the team, collecting the data, and because that will give you an insight of what you're doing.
Yeah.
Good. And what do you know about feedback?
So I think feedback is very important to improve and to measure our performance against the standards. Because when I get a feedback, it makes me reflect and revise what was done right, what was done wrong, and how to improve that. And I think this is the best way to learn and progress. One
Good.
of the best ways to improve.
So you can tell them that without feedback, we are flying in dark. It's a good start, is it? Okay. So without feedback, we are like flying in dark. And what you said is good. So always we need to have a feedback to assess our performance. There is a formal and informal feedback. There is a verbal or written feedback. There is a patient and colleague feedback, and there's a consultant feedback. And always there is a positive and negative feedback. And you need to give an example. It is, if you didn't give an example, they will not give you any mark. So you said, like an example, I deliver a teaching session for the F1, and one of the feedback, it was written that I didn't stick to the time frame. So in the next time, I arrange myself to finish in the same time. Please don't, not everyone he will say the same, this example. But yeah, but this is a simple example, and it's easy to remember it. So I deliver teaching, they give me feedback that I'm not stick to the time, or there are a lot of feedback, but avoid any feedback related to patient or patient safety.
Yeah.
It's good.
Okay. Yeah.
Let's go for a clinical scenario. So there's a 29 years old female present with diarrhea 7 times with a mucus, abdominal pain, and her past medical history that she has IBD. She don't know what medication she's taking. How did you approach this patient? And I will put timer. When I put timer, I will tell you. Okay, yeah, timer is going. Yes.
Okay.
How you approach this patient?
So I would first of all take a quick look at where the setting, which setting we are, how unwell she is. Is it that she needs to be in a HDU unit, like very low blood pressure? Is she in shock, hypovolemic shock, or what's going on with her? Or is it something that can be managed in clinic or on the wards, or in ED, just like a non-HDU setting? And then I would like to take further details about the history. I would like to analyze her diarrhea, for how long it was. Is it chronic, or is it an acute, short-lived? I know that she has a IBD in the background, so I think that provisionally this might be a flare of her IBD. I would like to assess if there is any weight loss, any abdominal pain, any symptoms of a possible acute abdomen. Is there any vomiting? Is there like hematemesis, or just vomiting, or not at all? Any PR bleeding? And then I would like to examine her for signs of hypovolemia, any signs of dehydration, and then further, if there are any extraintestinal manifestations. And then I would like to send off some collect a background history, especially gastrointestinal history. Is she known to the gastroenterology team? What medications have she been? Is there anything on her records, if possible? Has she been started on any treatment? Any change in her treatments? Has she been compliant with her medications or not? What about any alcohol, smoking history, recent travel, any information that I can gather from like infective on top of a chronic diarrhea. After that, I will send off some stool samples. We don't know about her medication, so it's a bit difficult, but however, we can get that from a collateral history later on if available, or from the notes. I'll send off blood samples, and I would like to do routine bloods, full blood count, CRP, inflammatory markers, LFTs, UNEs to check for AKI, electrolytes, and then a fecal calprotectin. I would like to send for a biologic screen as well at the same time. And then if by the abdominal examination, if she has any abdominal pain, and especially if it's like a significant pain, I would like to do some imaging. Sometimes it's okay to do, if it doesn't alarm like an acute abdomen, just an X-ray, or just scan her if there is any suspicion of a toxic megacolon or any collections.
What did you expect in the X-ray?
Sorry, say that again. Sorry.
What did you expect in the X-ray?
So I don't know if she has ulcerative colitis or if she has Crohn's. It's IBD, which it's not clear. But if we assume that she has bloody diarrhea with mucus, I would say ulcerative colitis. So I would like to rule out toxic megacolon or perforated air under the diaphragm with a chest X-ray. And then a lactate could be helpful as well among the blood tests. If she had in the background, she was Crohn's disease, I would like to do a CT scan if she's febrile and toxic to rule out any collections, again, bowel perforation as well. And then start her own treatment. Of course, it's very useful to do the true love with score as well to classify the severity. Let's assume that she has colitis, the severity of her colitis. And then the treatment would be IV steroids. If her inflammatory markers are raised, I would cover her with IV antibiotics as well to cover for infection. And it depends about the level of the CRP, how toxic she is, if there are any signs of like chest symptoms, urine symptoms, other infection going on. IV steroids, and then I don't know, her medication. I don't know if what she's taking. That's a tricky bit. And then
so
IV fluids.
How you start managing her?
So I would start resuscitate, like rehydrate her, IV fluid, insert 2 large bore cannulas, or 1, depending on how severely dehydrated she is. Start rehydrating her with IV fluids, correct any electrolytes imbalance, intravenous steroids, VTE prophylaxis, because IBD patients are prone to have prothrombotic state. And then
what do you think if this patient has 3 days of steroid and not to improve, how you will assess her again?
So she's had IV steroids not improving. She needs a biologic screen before deciding on escalating her treatment. But I would involve my consultant, of course, in the decision. It's usually a consultant or MDT decision on what biologic agent she starts on. If she doesn't improve on steroids after 72 hours, then there might be a decision to escalate her management. A rescue therapy, biologic.
I didn't hear the.
So if the patient is not improving on intravenous steroids within 72 hours, then reassessment would be with
which
like,
score? Good. So the time is finished. Okay. Yeah. So this is the idea when you have the case scenario. So usually they don't talk. They just look to you, and this is surprising. So sometimes you will not understand why they are just quiet, and sometimes say, "Hello, did you hear me?" So again, you start well. So the things that when you start that I'm going to see where this patient will be treated in the ICU or HDU. So just make it in one sentence that I need to make sure this patient will be treated in the safe place when I'm reviewing him or her.
Yeah.
So it's just when I review this patient, I need to make sure the place is safe for her to be reviewed. So maybe she will need resuscitation or maybe she will need HDU. This is first. The second, the feedback for this, you ask about diarrhea, but the important question in the area of colitis, you need to ask how frequent, for how long, is there any blood, and is there any vomiting?
Yeah, and I asked.
Yeah, you ask later on if there are any BR bleeding, but I mean, it's just more structuring your question.
Okay, yeah.
You raise the issue of infection later, but you should make it, so 3 differential diagnoses you have here. So you can say, I believe this is acute flare-up of ulcerative colitis or IBD, but I need to rule out acute abdomen. I need to rule out acute infection. And when the patient is coming with colitis and there is suspicion of infection, as I said, in the management, you will decide to admit or not. So you said, I will admit this patient to side room, and you forget to send stool sample for culture and C. diff.
Oh, yeah.
Yeah, but I understand that in the practice you did it very well, but in the how to say it, so you just need to familiarize yourself. History, examination, investigation. And when you request investigation, you said full blood count and CRB looking for inflammatory marker, a blood like UNEs looking for any AKI, X-ray looking for megacolon and a thumbprint.
Thumbprint, yeah.
Thumbprint. The air under diaphragm and perforation should be by chest X-ray. So if you have any suspicion there's perforation, it should be CT scan, no X-rays. Okay, and when you start, the management is good idea. You mentioned the score, and it is like IV fluid resuscitation, IV steroid, VTE prophylaxis. If there are any involvement of other specialty, like if this patient, maybe she will have a stoma, I will involve the stoma. I will involve the IBD nurse or stoma nurse, nutrition, because this is the communication we talk about it. So in the management, you said, I need to involve my IBD nurse, I need to involve the nutrition team. She's lady, she's female, so maybe she's pregnant. I need to make sure she's not pregnant. What you said about biologic screen is good, and that's give like a bonus in your. So in the end, you need to say, ideally, this patient should be admitted and have a sigmoidoscopy with CMV biopsy within 24 hours. Yes. And after 3 days, we need to reassess by ASCU score, and that will decide whether this patient, he will need surgery or not, and that include the CRB and other blood. Yes. Cool. So I think your answer is good, but you just need to structure it. So you ask about past medical history, which is important. The only thing I didn't ask in my case, I didn't ask if this patient has admission or not, and they give me 9 from 10. And that's in the feedback. He did not ask about previous admission. Okay. Yeah, and again, it's depend, but there is a nice guideline with, I think, with the flow chart. Just read it and master it. Usually they ask about it. Okay. And what's your presentation? Did you prepare one or not?
Well, I actually have a case report which is accepted in the American College of Gastroenterology. It's still under press, so it's going to be published maybe the next week. So I'm planning to present it. Okay.
So I will start the time, and I told you to present it for me. Okay. Yeah. Yes. Could you present your case?
Yeah. So this is 33-year-old female who was diagnosed with Crohn's disease 3 years back. She was treated with azathioprine, steroid responded well to them, and then her treatment was escalated to infliximab. It controlled her symptoms. She was under regular follow-up, but then she started to develop stricturing Crohn's, and she presented to the hospital with 4 admissions, admitted with intestinal obstruction, which was treated conservatively within 2 months. And then the last time she was admitted, this time she had her intestinal obstruction didn't actually resolve with conservative treatment, and a CT scan proved that there was significant bowel obstruction in the terminal ileum. distal third of the ileum, and an urgent laparotomy was decided to be done in order to explore this obstruction and treat it. And intraoperatively, it was found to be a large Meckel's diverticulum tumor, which was craggy and hard and malignant with mesenteric lymph nodes, which was excised, and also she had some bowel resection as well. And then following that, she was treated with chemotherapy for 3 months, but unfortunately she didn't respond well to it, and that led to another massive bowel ischemia with a further resection of her bowel. So she only had 150 centimeters of small bowel left. She was treated with palliative chemo afterwards, and then she started to deteriorate, and after that she developed sepsis and another episode of bowel obstruction, which was decided to be treated conservatively, no place for any further surgical resections or treatment. And she eventually was admitted to ITU and with sepsis, and she passed away. So my learning point of this case report is we know that she has Crohn's in the background, and she presented with stricturing Crohn's, and that was multiple times of presentation with a bowel obstruction, which didn't respond anymore to infliximab or any conservative treatment. In a young female, the learning point is, if that happens, not always to refer the presentation every time to the original background diagnosis. So it could be something else going on there. She was investigated very well with small bowel MRI scans, CT scans, etc. But Meckel's diverticulum doesn't show up on those scans. So it's a rare presentation, but the learning point is not always to refer the presentation of each admission to the original background diagnosis. Always think that there might be something else going on that needs to be investigated.
Okay, good. So your time is 3 minutes, around 20 seconds. Again, it should be 4 minutes.
Okay.
And believe me, they will say that. I think it's a good case and interesting. So I just, maybe what you can do, just write it in Word or a paper and make it in 4 minutes, and try to emphasize that this patient has a Crohn, recurrent obstruction. She has a recurrent admission, recurrent external obstruction. And the learning point was we need to be open-minded even in the background of of the disease, and we should not only stick to the diagnosis of the previous illness. And I think here you need to mention an ethical issue or something, that if this patient not responding, so she should have early palliative treatment care or discussion. So again, one learning point is not very interesting. So again, you said that's good. It's we will be open-minded, but again, another learning point, it should come like at least 3. So you said, I learned we should work in a team with a surgeon, okay? And I learned also the complicated cases and how that impacts like emotionally to the patient and family, and we involve in a lot of good discussion. And again, we need to be open for the diagnosis. So just sit with yourself, reform. It is a good case. The presentation should be 4 minutes. And then again, after that, they will ask you, what do you think about Crohn's disease? What do you think the criteria for surgery? And if this patient is going for surgery, which immunotherapy is better? And why this patient develop antibody? What's the things you can make it to decrease the antibody, infliximab antibody formation? And I think it's a general question. But again, the presentation from beginning that I was involved in the treatment of a patient. She is known to have a Crohn's disease with multiple admission. Unfortunately, she developed antibody to infliximab. And they will ask you why they didn't escalate the treatment for the jack, or why they didn't escalate the treatment for the other. So I think you need to form it in a way they will not ask you too much question, and you will not put a gap, not understand. Like for me, when I heard the case, why they didn't give her cyclosporine? Why?
Yeah.
Yeah, why? Because
You mean before the resection or after?
Even after the resection, why they didn't optimize her medically? Why they didn't give the JAK inhibitor? So you need to make your presentation. What you say,
Okay.
it should be clear. Like you're going to tell me, this patient, she was on Fleximab, but unfortunately she's not responsive, so we did for her surgery. Why we did for her surgery? Because there are another second line or third line of treatment, and why she had the resection exactly, what was the indication, what's the criteria we assess her for the surgery. Yeah, so usually this is, I think, when you wrote your case report, definitely it was very good, so you just need to write it and make the information from it. Yeah, I think overall is good. Just some organization and just practice with anyone, with a family or anyone, or you can present the case for your consultant, told them, or I have this case I want to present in front of you. What's your advice? And usually the consultant, they have, especially if someone work with research, they have good advice. They will tell you, no, don't say this point, say this point.
Yeah.
Okay, do you have any question?
Well, so I haven't actually like seriously starting preparing yet. It's just that any advice for me regarding the most station that I feel would be the most difficult, maybe I think is the case. I'm not sure. I don't know what to expect. Which case scenario will come up.
Usually they don't bring difficult cases. So they will tell you, the ED call you, they have a patient with hematemesis, how you approach this patient. But from beginning, you need to show that you work in the gastroenterology. You say, okay, the first thing I want to make sure this patient is treated in the resuscitation, and I need to find whether this is varicose or non-varicose bleeding, which is completely different in the management. Then I will take short history from him. I will ask about the amount, frequency, is this first time, is there any blood thinner medication? So from beginning, you need to show to them that you know what to do, okay? Yeah. Like this patient, oh, I believe this patient is acute flare-up of colitis, but I need to rule out any acute abdomen or infective. They will feel relaxed after hearing that.
Okay.
Yeah, usually they don't bring difficult cases. There is optimized interview. They have good, the website, they have a very good cases presentation. So maybe it's worth it to read it or to check it.
Okay.
But they will not bring something very strange. They will bring something straightforward, but they need the approach of where I treat the patient, history, examination, investigation, management plan, ongoing care.
Sure. Okay.
Good.
All right. Thank you very much.
Welcome. And the question, is there any specific criteria for presentation or any? So the presentation, they want any case that you involve in it, and it was with learning point. So it's not should be like rare case or rare presentation. Any case you involve in the treatment, and you did some communication with the other team, and you find some learning point. Okay, I think we answer all the question. I'll be grateful if you fill the feedback form, and if there are any question, you can contact me by. I'm in many groups, but I'm not sure if anyone. I'm going to write my email in the chat box, so just drop me an email and I will try to answer any question I can. Okay, and thank you all, and
Thank
hope
you.
the best. Yeah, assalamu alaikum.
Assalam.